Okay, so I'm gonna erase this. Does anybody need a picture? You're good? Okay. So anaphylaxis, you're gonna have that massive inflammatory response. And so the epi is gonna assist with decreasing that to like decrease the amount of blood flow, especially to your airway, so that you don't have so much inflammation that your throat closes, you know, that type of thing. And then of course antihistamine, Benadryl, diphenhydramine. All right.
I had a patient the other day that I picked up that was allergic to diphenhydramine. What else would they give him?
That's a really good question. Most of our patients like Benadryl. I don't know, but I'm sure there's another antihistamine that they would take.
Yeah, they probably had a list.
Yeah. They have protocols, which is pretty cool. Like they have this coming in, they have a protocol, and here's all the meds for it. It's like they have different things.
Okay, so we talked about treatment, we talked about causes, and identifying the cause is really one of the most important things. So knowing keywords that help you kind of identify, oh, this person's at risk for this kind of shock, or this looks like a result of this kind of shock, and this is how I'm going to treat it. So figuring out what kind of shock is super important, you know, to figure out how to treat it. Okay, so signs and symptoms in general of shock are gonna be what?
Hypotension.
Okay, so low blood pressure,
Depends if you're talking about early shock, late shock,
just shock in general.
Increased heart rate.
clammy.
Increased heart rate, clammy,
Increased respiratory rate.
Okay, so when a patient is in shock, sorry, Betty, you're gonna go into shock. And one arm's longer than the other. Doesn't matter. Okay, so Betty here is in shock. So she's got her heart, okay, and she's got her body, right, full of organs, and this heart has a certain volume, 5 or 6 liters probably, right? And this heart has to pump this volume to all of these places to perfuse all the organs, right? Okay? In shock, it's like the container gets bigger because everything is vasodilated. So now the heart has to pump this same volume around a bigger container, which is why it pumps faster. If we look at cardiac output, it's stroke volume times heart rate. So the stroke volume, we still have the same volume. So the body's going to increase the heart rate to try to fill the container. Okay? And the container gets bigger because of the vasodilation. That's my best explanation for the mechanism of shock. We get clammy because we're vasodilated and we just don't have as much perfusion to all the little capillaries and stuff. We could have a temp, but we agreed that it could be up, it could be down. Usually we see the high temp. Shock develops often slowly, except for anaphylaxis is fast, right? So there's usually signs and symptoms that we see before the patient kind of crashes and needs rapid response, before their perfusion is compromised. And we're looking at level of consciousness changes, right? And then vital signs. So you have to keep an eye on those so we don't end up with a failure to rescue.
5244. Dr. Correct, 5244.
So if you don't see those things happening, that's what the computer is helping us with. It'll say, hey, pay attention, we have a SIRS, we have an inflammatory response, pay attention, now we have sepsis, you know, that kind of stuff. And it's pulling, every time that you chart, every time a lab value comes back, it's saying, okay, these together put you at higher risk for sepsis, so you need to go and check it out. Okay, so that is the mechanism for that. So we talked about, so are there any differences? So there's all shock, right? Any difference between all the shocks and hypovolemia in signs and symptoms? Or are there any signs and symptoms that might be more tied more to hypovolemia? Anything else?
Decreased cardiac output?
The cardiac output thing is hard because it goes down at some point, but like in the beginning, it's higher because you are pumping faster, right? This is a multiplication problem. So if either one of these increases, all of it increases until you get worn out, and then it goes down. So that's kind of a hard one to say for everything. So how about decreased urine output? And maybe like the skin,
Cyanosis.
right? Yeah, they might develop cyanosis. So the things that tell you a patient is dry, right? Any labs or anything that might go along with hypovolemia?
Hemoglobin, H&H.
How do the H and H change?
It decreases and,
So if we're bleeding,
yeah,
our H and H will go down,
yeah,
right?
yeah.
Our BUN is gonna be elevated.
And creatinine elevated.
Creatinine might
Oh,
be okay.
dehydration, never mind, yeah.
Yeah, so BUN is high. When the kidneys don't have enough fluid to process, they're gonna break down more proteins and end up with a high BUN. So those are some things that might stand out over the other stuff. What about cardiogenic? Are there any signs and symptoms that might be different for that?
Elevated troponin.
Okay, so elevated troponin. There's a lab we use for heart failure,
BNP.
BNP. So if the BNP is elevated, then they're in heart failure. Heart failure, the pump doesn't work. Okay. If they have tamponade, I'm gonna put it down here. So tamponade is also a little bit unique. You still have shock, but if you took this picture and you did tamponade, so now we have our pericardial sac is full of blood, right? So blood can't get in, right? It can't get in and it can't get out. Okay, it's all just stuck in there. So you won't be perfusing because the fluid's kind of just all out here. And I mean, we have a little bit of muscle activity inside of our vessels, but not enough to like perfuse anything. So it's gonna squeeze the heart until the heart just can't pump anymore, right? So you're gonna, as far as treatment, because I didn't mention this before, you're gonna treat with fluids to try to, which sounds weird, to try to support the blood pressure, okay? And then you have to surgically treat it. So somebody's gotta stick a needle in there and pop the sac to get the blood out. Okay, so they could just put a needle in there. They could put a tube in there with a drainage bag. They could crack the chest and be real dramatic. They could take them to the OR. They could put a chest tube in, any of those kinds of things. But, you know, they just have to open this up and drain it, okay? But you're still gonna have low blood pressure. You will not have high heart rate. you're gonna have dysrhythmias. Okay, and then, so I guess dysrhythmias could be up here too. Neurogenic has a symptom that is different from all the rest. Brady, sinus Brady. So in most shocks, the sympathetic nervous system is what kicks in. So what is released when we have the sympathetic nervous system stimulated? Yes, it's fight or flight, so it's the epinephrine, norepinephrine. And everything is increased, right? Your heart rate and your, because you're trying to get blood to your brain and you're trying to run away, right? When we have a neuro issue, it's not the sympathetic nervous system, it's like blocked. So we end up with the opposite. So we end up with a sinus Brady. So that is a unique symptom to a neuro shock patient. Okay? Septic, what things are unique about sepsis? I've mentioned some already.
So for neuro, it's just sinus Brady.
It's just sinus Brady, and then they had something neurological.
The bands.
Yeah, so elevated bands. Do we know what bands are? What are bands?
Are they like the young
The
white blood
immature,
cells?
Yeah, good. So the bands are the troops that are in basic training. Okay? They know they're going to go fight a war, but they don't know how to do it yet, and they haven't been given specific roles. Okay? So that tells us that something is brewing somewhere and the body is mounting a response. Okay? So the bands aren't really, and this is totally layman's terms. Somebody out there is going, oh my God, that's totally wrong. But for our purposes, the bands just tell us that something is, the body's getting ready to fight something. Okay? When you look at the WBCs on the lab report, those are the mature white blood cells that have been through basic training that are actually out fighting the infection. Okay? Until we use them up. So elevated bands are pretty telling that we have sepsis going on. Okay? So if I have a patient with high bands and their blood pressure drops, I'm going to think fluids and I'm going to think Levofed. Okay, and then we might have some cultures if we're lucky. Invasive procedures, or they have invasive lines. Okay, highly susceptible to infection.
Are those things that cause sepsis, or those things that?
Those are things that you're going to see in your patient. Yeah, yes, causes, but you might also, like we could culture the catheter tip or, whatever. Okay, so that's sepsis, and then anaphylaxis, we're most concerned about airway, right? So anything that is, makes us think that the airway is compromised. The patient is coughing, or they have a scratchy throat, anything that could be very vague but related to your throat. Or they just have a rash, or something. It could be something real subtle. It could be something real obvious. They got stung by a bee, But that one's pretty easy because it's, epi and antihistamines. Okay, so that's kind of the symptoms that are, unique to each one, but a lot of it is about identifying the cause, and a lot of the treatments are the same. You've got to treat the underlying cause, so we're treating infection or something with the spinal cord, that kind of stuff. Questions, concerns about that? So these are considered distributive shocks. I don't know if they put those together for you. So distributive shock, you have all the right amount of fluid, but it's distributed elsewhere in your body where you can't necessarily use it. So that's what makes it distributive. I don't like that they have all these different names. Or circulatory shock is another one. It's like, well, aren't they all circulatory? They're talking about the fluid is out in your circulation and not, able to fill the container. So circulatory, distributive, those are kind of all the same. Okay?